Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, student nurses. My name is Criselmer Ducanes, clinical instructor teaching fundamentals of nursing practice. Today, we will be talking about documenting and reporting. What is an effective communication? Effective communication among health professionals is vital to the quality of client care. Generally, health personnel communicate through discussion, reports, and records. A discussion is an informal oral consideration of a subject by two or more healthcare personnel to identify a problem or establish strategies to resolve a problem. When we say report, it is an oral, written, or computer-based communication intended to convey information to others. For instance, nurses always report on clients at the end of a hospital work shift. What is record? It is also known as chart or client record. It is a formal, legal document that provides evidence of a client's care and can be written or computer-based. So what is documenting? It is also known as recording or charting. The process of making an entry on a client record. Now let's proceed to the purposes of client records. Client records are kept for a number of purposes, including: first, communication. The record serves as the vehicle by which different health professionals who interact with the client communicate with each other. This prevents fragmentation, repetition, and delays in client care. Next is planning client care. Each health professional uses data from the client's record to plan care for the client. A primary care provider, for example, may order a specific antibiotic after establishing that the client's temperature is steadily rising and that laboratory tests reveal the presence of a certain microorganism. Nurses use baseline and ongoing data to evaluate the effectiveness of the nursing care plan. Next is auditing health agencies. An audit is a review of client records for quality assurance purposes. Accrediting agencies, such as the Joint Commission, may review client records to determine if a particular health agency is meeting its stated standards. Next is research. The information contained in a record can be a valuable source of data for research. The treatment plans for a number of clients with the same health problems can yield information helpful in treating other clients. Another one is education. Students in health disciplines, such as in nursing, often use client records as educational tools. A record can frequently provide a comprehensive view of the client, the illness, effective treatment strategies, and factors that affect the outcome of the illness. Next is reimbursement. Documentation also helps a facility receive reimbursement from the federal government. For a facility to obtain payment through Medicare, the client's clinical record must contain the correct diagnosis-related group codes and reveal that the appropriate care has been given. Next is legal documentation. The client's record is a legal document that is usually admissible in court as evidence. In some jurisdictions, however, the record is considered inadmissible as evidence when the client objects because information that the client gives to the primary care provider is confidential. Next is healthcare analysis. Information from records may assist healthcare planners to identify agency needs such as overutilized and underutilized hospital services, Records can be used to establish the costs of various services and to identify those services that cost the agency money and those that generate revenue. Now let's discuss documentation systems. A number of documentation systems are in current use. The source-oriented record, the problem-oriented medical record, the problem, intervention, evaluation or PI model, focus charting, charting by exception or your CBE, computerized documentation, and case management model. These documentation systems can be implemented using the traditional paper forms or with electronic health records. Now let's discuss source-oriented record. We have your traditional client record, and it can easily locate forms on which to record data and easy to trace information specific to one's discipline. Each person or department makes notations in a separate section or section of the client's chart. For example, the admissions department has an admission sheet, the primary care provider has a physician's order form, the physician's history sheet, and progress notes. Nurses use the nurses' notes, and other departments or personnel have their own records. Next is narrative charting. It is a traditional part of the source-oriented record. It consists of written notes that include routine care, normal findings, and client problems. There is no right or wrong order to the information, although chronological order is frequently used. Next, let's proceed to problem-oriented medical record. It is also known as the problem-oriented record or POR. The data are arranged according to the problems that the client has rather than the source of information. Members of healthcare team contribute to the problem list, plan of care, and progress notes. Plans for each active or potential problem are drawn up, and progress notes are recorded for each problem. We also have advantages of your POMR, or problem-oriented medical record. It encourages collaboration, and the problem list in the front of the chart alerts caregivers to the client's needs and makes it easier to track the status of each problem. Next is the disadvantages of POMR. We have caregivers differ in their ability to use the required charting format, and it takes constant vigilance to maintain an up-to-date problem list. And lastly, we have assessments and interventions must be repeated, so this becomes inefficient. The POMR has four basic components. First is the database. We also have the problem list, the plan of care, and progress notes. In addition, flow sheets and discharge notes are added to the record as needed. Let's discuss database. The database consists of all information known about the client when the client first enters the healthcare agency or hospital. It includes the nursing assessment, the primary care provider's history, social and family data, and the results of the physical examination and baseline diagnostic tests. Data are constantly updated as the client's health status changes. Next is problem list. The problem list is derived from the database. It is usually kept at the front of the chart, and it serves as an index to the numbered entries in the progress notes. Problems are listed in an order in which they are identified, and the list is continually updated as new problems are identified and others resolved. And the lists are continually updated. Now let's proceed to plan of care. It is generated by the individual who lists the problems, and it is made with reference to the active problems. Now let's proceed to progress notes. A progress note in the POMR is a chart entry made by all health professionals involved in a client's care. So we have here the supplier format, which includes the subjective data, objective data, assessment, plan, interventions, evaluations, and revisions. Now let's proceed to PI model. The PI documentation model. PI is an acronym for Problems, Interventions, and Evaluation of Nursing Care. It consists of a client care assessment flow sheet and progress notes, and it eliminates the traditional care plan and incorporates an ongoing care plan into the progress notes. Now let's proceed to focus charting. It is intended to make the client and client concerns and strengths the focus of care. And it provides a holistic perspective for the client and the client's needs. So it is organized into 3 columns. So we have the date and time, the focus, and progress notes. When we say focus, it may be a condition, a nursing diagnosis, a behavior or a sign or symptom, an acute change in the client's condition, or a client's strength. When we say progress notes, these are organized into data, which reflects the assessment phase of the nursing process. We also have the action. It reflects the planning and implementation and includes immediate and future nursing actions. Then we have the response. It reflects the evaluation phase of the nursing process and describes the client's response to any nursing and medical care. Now let's proceed to charting by exception, or your CBE. This is a documentation system in which only abnormal or significant findings or exceptions to norms are being recorded. Charting by exception incorporates 3 key elements. We have the flow sheets. Examples of flow sheets include graphic records of a vital sign sheet, a head and face assessment in a daily nursing assessment record, and a Braden assessment of the skin. We also have the standards of nursing care. Documentation by reference to the agency's printed standards of nursing practice eliminates much of the repetitive charting of routine care. Lastly, we have the bedside access to chart forms. In the CBE system, all flow sheets are kept at the client's bedside to allow immediate recording and to eliminate the need to transcribe data from the nurse's worksheet to the permanent record. The advantages to this system are that it eliminates lengthy, repetitive notes and it makes client changes in condition more obvious. Next, let's proceed to computerized documentation. It is your electronic health records, or EHR. It is used to manage the huge volume of information required in contemporary healthcare. That is, the EHR can integrate all pertinent client information into one record. Nurses use computers to store the client's database, add new data, create and revise care plans, and document client progress. Some institutions have a computer terminal at each client's bedside, or nurses carry a small handheld terminal, enabling the nurse to document care immediately after it is given. Next is the case management model. The case management model emphasizes quality, cost-effective care delivered within an established length of stay. This model uses a multidisciplinary approach to planning and documenting client care using critical pathways. These forms identify the outcomes that certain groups of clients are expected to achieve on each day of care. Along with critical pathways, The case manager model incorporates graphics and flow sheets. Progress notes typically use some type of charting by exception. For example, if goals are met, no further charting is required. A goal that is not met is called a variance. A variance is a deviation from what was planned on the critical pathways. Unexpected occurrences that affect the planned care or the client's responses to care. When a variance occurs, the nurse writes a note documenting the unexpected event, the cause, the actions taken to correct the situation, or justify the action. The case management model promotes collaboration and teamwork among caregivers, and it helps to decrease length of stay and makes efficient use of time. Now let's proceed to documenting nursing activities. The client record should describe the client's ongoing status and reflect the full range of the nursing process. Regardless of the record system used in an agency or hospital, nurses should document evidence of the nursing process on a variety of forms throughout the clinical record. So we have to document the admission nursing assessment, nursing care plans, card access, flow sheets, progress notes, and nursing discharge or referral summaries. For the admission nursing assessment, it is also referred as initial database, nursing history, and nursing assessment. And it is completed when the client is admitted to the nursing unit. We also have the nursing care plans. We have two types of nursing care plans. We have the traditional, which is written for each client. And also we have the standardized. It is developed to save documentation time. Next is cardexes. It is widely used, concise method of organizing and recording data about a client, making information quickly accessible to all health professionals. The system consists of series of cards kept in a portable index file or on computer-generated forms. The cards for a particular client can be quickly accessed to reveal specific data. The cardex may or may not become a part of the client's permanent record. In some organizations, however, it is a temporary worksheet written in pencil for ease in recording frequent changes in details of a client's care. Next is flow sheets. A flow sheet enables nurses to record nursing data quickly and concisely, and it provides an easy-to-read record for the client's condition over time. We have here an example: graphic record, intake and output record, medication administration record, and skin assessment record. Now let's proceed to progress notes. Progress notes made by nurses provide information about the progress a client is making toward achieving desired outcomes. Therefore, in addition to assessment and reassessment data, progress notes include information about the client problems and nursing interventions. Next is nursing discharge or referral summaries. A discharge note and referral summary are completed when the client is being discharged and transferred to another institution or to a home setting where a visit by a community health nurse is required. Now let's have the general guidelines for recording. Because the client's record is a legal document and may be used to provide evidence in court, many factors are considered in recording. Healthcare personnel must not only maintain the confidentiality of the client's record, but also meet legal standards in the process of recording. This includes the date and time. Document the date and time of each recording. Next is timing. Follow the agency's policy about the frequency of documenting and adjust the frequency as client's condition indicates. For example, a client whose blood pressure is changing requires more frequent documentation than a client whose blood pressure is constant. Next is legibility. All entries must be legible and easy to read to prevent interpretation errors. Next is permanence. All entries on the client's record are made in dark ink so that the record is permanent and changes can be identified. Next is accepted terminology. Abbreviations are used because they are short, convenient, and easy to use. People are often in a hurry and use abbreviations when texting or text paging. Abbreviations are convenient. However, they are often ambiguous. The ambiguity places the client at risk for medical errors and significant harm, possibly even death. Next is correct spelling. Correct spelling is essential for accuracy in recording. If unsure how to spell a word, look it up in a dictionary or other resource book. Next is signature. Each recording on the nursing notes is signed by the nurse making it. Next is accuracy. The client's name and identifying information should be stamped or written on each page of the clinical record. The other one is sequence. Document events in the order in which they occur. For example, record assessments, then the nursing interventions, and then the client's responses. Next is appropriateness. Record only information that pertains to the client's health problems and care. Any other personal information that the client conveys is inappropriate for the record. Recording irrelevant information may be considered an invasion of the client's privacy and/or libelous. Next is completeness. Not all that a nurse obtains about a client can be recorded. However, the information that is recorded needs to be complete and helpful to the client and healthcare professionals. Next, we have conciseness. Recordings need to be brief as well as complete to save time in communication. Lastly, we have legal prudence. Accurate, complete documentation should give legal protection to the nurse, the client's other caregivers, the healthcare facility, and the client. Now let's discuss reporting. The purpose of reporting is to communicate specific information to a person or group of people. A report, whether oral or written, should be concise, including pertinent information, but no extraneous detail. Now let's discuss the change of shift reports. Incomplete handoff communication is associated with sentinel events that will result in adverse healthcare outcomes or even death. As a result, a hospital is required to implement a standardized approach to handoff communication. When we say handoff communication, it is defined as a process in which the information about the patient or the client or resident care is communicated in a consistent manner, including an opportunity to ask and respond to questions. Now let's discuss the ISBAR handoff communication tool. It allows for an easy or focused way to set expectations for what will be communicated and how between members of the team, which is essential for developing teamwork and fostering a culture of patient safety. So it is composed of introduction, situation, background, assessment, and recommendation. When we say introduction, you have to state your name, your unit, and the client name. Then, for the situation, you have to discuss briefly or state the problem or the situation. Then for the background, you have to state the client's admission diagnosis and date of admission. You also need to state pertinent medical history and provide brief summary of treatment to date. And lastly, the code status of your patient. Then, you have your assessment. You have to report the vital signs, the pain scale. Is there a change from previous assessment? So you have to report this elements under your assessment. Then for the recommendations, which is the last component of your ISBAR, you have to state what you would like to see done or specify that the care provider needs to come and assess the client. Ask if the healthcare provider wants to order any tests or medications, and you also have to ask the healthcare provider if she or he wants to be notified for any reason. And of course, you have to ask if there will be no improvement, when you should call again. Now let's proceed to telephone reports. Healthcare professionals frequently report about a client by telephone. Nurses inform primary care providers about a change in a client's condition. A nurse may report to a nurse on another unit about a transferred client. The nurse receiving a telephone report should document the date and time, the name of the person giving the information, and the subject of the information received, and sign the notation. The person receiving the information should repeat it back to the sender to ensure accuracy. When giving a telephone report to a primary care provider, it is important that the nurse be concise and accurate. The ISBAR communication tool is often used for telephone reports. Telephone reports usually include the client's name and medical diagnosis, changes in nursing assessment, vital signs related to interventions. The nurse should have the client's chart ready to give the primary care provider any further information. Now let's proceed to telephone orders. Primary care providers often order a therapy, like for example a medication, for a client by telephone. Most agencies have specific policies about telephone orders. Many agencies allow only registered nurses to take telephone orders. While the primary care provider gives order, you have to write the complete order down on the physician's order form and read it back to the primary care provider to ensure accuracy. Also, you have to question the primary care provider about any order that is ambiguous or unusual, example, an abnormally high dosage of a medication, or contraindicated by the client's condition, and have the primary care provider verbally acknowledge the readback of the verbal or telephone order. Then indicate on the physician's order form that it is verbal order or telephone order. Once the order is written on the physician's order form, the order must be countersigned by the primary care provider within the time period described by the agency policy. Many acute care hospitals require that this be done within 24 hours. Now let's proceed to care plan conferencing. A care plan conferencing is a meeting of a group of nurses to discuss possible solutions to certain problems of a client, such as inability to cope with an event or lack of progress toward goal attainment. The care plan conference allows each nurse an opportunity to offer an opinion about possible solutions to the problem. Other health professionals may be invited to attend the conference to offer their expertise. For example, a social worker may discuss the family problems of a severely burned child, or a dietitian may discuss the dietary problems of a client who has diabetes. Next, we have your nursing rounds. Nursing rounds are procedures in which 2 or more nurses visit selected clients at each client's bedside. The purpose of your nursing rounds are obtain information that will help plan nursing care and provide clients the opportunity to discuss their care and evaluate the nursing care the client has received. During rounds, the nurse assigned to the client provides a brief summary of the client's nursing needs and the intervention being implemented. Nursing rounds offer advantages to both clients and nurses. Client can participate in the discussions, and nurses can see the client and the equipment being used. To facilitate client participation in nursing rounds, nurses need to use terms that the client can understand. I believe this is the end of our discussion on documenting and reporting. So thank you so much for listening.